This week on the BackTable Podcast.
And we're starting to see that VivAer is actually incredibly good for a whole lot of patients, and it will do more than we think. And the other thing is, you know what? If it fails, I can always bring them back and do a big operation. And I've done that a number of times, and I tell people, I was like, look, this may not be enough for you. I would just go for the big thing. And I have been pleasantly surprised a number of times that people are like, no, I'm fine. I don't want anything else. Cool. Love it.
Aerin Medical offers innovative, non-invasive treatments that help patients with NAO breathe easier and sleep better. VivAer has been clinically demonstrated to significantly improve breathing due to NAO and resulted in better sleep quality, daytime sleepiness, and reduced snoring. Performed in an office or OR setting, no incisions, no implants, just lasting relief. Learn more at vivaer.com or from your Aerin Medical representative.
We have a great guest. We're going to talk about OSA. We have Dr. Scott McCusker, who is an otolaryngologist and facial plastic surgeon at Mercy Medical Group, Dignity Health in Sacramento, California. He's also the president-elect for the American Board of Facial Cosmetic Surgery. And he's here today with us. We're going to talk about the impact of addressing nasal airway obstruction on obstructive sleep apnea. Welcome to the show, Scott.
Thank you so much. Honored to be here. Appreciate y'all.
So before we get started, tell us a little bit about you, about yourself, your practice, your background.
Sure. So like you said, I'm an ENT in Sacramento. I have a wide range of things I see. I am a generalist who focuses on a few additional things, namely sleep and facial plastics, like you mentioned. Also do a lot of sinus work. I was in the Air Force for most of my career. I got out in 2020 in May when nothing else was happening in the world. Was lucky I was stationed at Travis Air Force Base at the time, so right down the road. We didn't even have to move, just fell right into my new job in Sacramento and have been very happy there since.
And Scott, how did you develop your interest in facial plastics?
So that's kind of been a long time thing for me. I think, that was a lot of what drew me into ENT in the first place. But then my residency with the military, I was lucky to work with some really amazing facial plastic surgeons and get to see a lot there and do a lot there, especially a lot of the reconstructive work for soldiers who are injured. I think that's something that's been very gratifying. And also the mix of kind of functional and cosmetic operations that we did so much of there. I have been able to still keep that going, which I like.
And as it relates to sleep, I think there's kind of a spectrum among ENTs as it relates to, how much, quote, sleep, you're doing. And so how has that come into your practice? Did you train in sleep when you were in training, or is it something you've kind of folded in and picked up as these new procedures and technologies have come on board?
So I think it's been a big evolution. And so in my residency, we had two people who were fellowship trained in sleep. We're both excellent. I learned a lot from them, but I'm getting older now. I finished residency before Inspire was even on the market. And when people were, kind of talking about it as this, historical or this futuristic kind of thing that may happen during your life. So I didn't have as much interest in sleep at the time because all we had was UP3s and patients were miserable. And it's a tough operation that doesn't work all that well.
Yeah.
And sure, if you combine it with other things, you have a good stepwise protocol, Stanford approach, all of that is great for the right patient, but it's a big thing. And it wasn't really until Inspire became more widespread that I really got interested in making sleep a bigger part of my practice. And it has taken off and taken over in a good way. I'm loving that. I actually just ran the numbers now. Almost a third of the operations I do are Inspire.
Okay. And so I would assume since you have such a big part of your practice that is dedicated to sleep, you probably have patients who are coming to you specifically with that complaint of snoring or OSA or something to that nature.
Absolutely. And we built in some pathways to try to get those patients taken care of because it is a huge unmet need. And, there's just so many people out there. The estimate is 20% of Americans have significant sleep apnea. Many of those are not diagnosed, as we know, but that's a ton of patients.
Yeah. And how are they presenting in your office? I mean, today we want to focus on like the nasal airway obstruction piece of it. Like, do you have to tease that out, or do they come in saying like, hey, I can't breathe through my nose and I snore? Or
I think it's a mix of things. So I see a lot of patients who come to me for nasal obstruction. And we kind of dig deeper and we realize that they've also got a sleep problem too. But I see it the other way of I see someone who comes to me with a known diagnosis of sleep apnea and they want an Inspire. And I just ask them like, how's it breathing through your nose? And they're like, oh yeah, I've never breathed well. And I broke my nose and I, this and that. And I'm like, we got to fix this too. We got to fix everything.
Is there a certain percentage in your practice of your OSA patients that also have nasal airway obstructive type symptoms, or like half, a third, or all of them?
So,
like, do we recognize it enough?
I think we don't do a good enough job of looking. I agree with you there. In my practice, I would say probably 70-80% of my sleep apnea patients have something with their nose that we make better. I'm probably a little skewed. I get that. But the data says that about 60% of people with sleep apnea have nasal obstruction as well. And treating the nasal obstruction gives you a better outcome. Doesn't necessarily fix the apnea. It may lower the AHI by a little bit, but it makes it much easier to treat. No matter how you're treating the apnea, it is easier to treat if you fix their nose.
And so as a part of, seeing these patients in clinic, do you use any particular like sleep questionnaires or nose scores to help have objective measures for how much nasal airway obstruction is a problem for these patients?
So the short answer is yes. And actually, I've shifted a lot of this where I handed a bunch of copies of these questionnaires to all the people who refer to me. And so I was like, here's a nose questionnaire. Have your patient do it. Here's all of these kind of things. And then patients usually come to me with a score already. And they're like, see, it says I need an operation. That's easy.
Wow.
That makes everyone's life better. In terms of my actual interview with the patient, I end up asking them the questions that are on these questionnaires, just conversationally and kind of organically. To me, it's more helpful that way. But again, a lot of these people already have a score. And I think it is a helpful tool. And especially, like I said, for the referring physicians, it's really helpful.
That's an interesting approach, Scott, to give the questionnaire to the referring physician, or, you know what I mean? Like, I've always thought about, okay, well, I got to give it to them in my clinic, but to actually put the step, in a different place of getting that information is pretty neat. Do a lot of patients come in with sleep studies as well, or having already been on PAP? Like, what's that?
Right. So for our sleep apnea patients specifically, we've made referral guidelines where they have to have a study within 2 years. They have to have tried CPAP. They've done all the pre-work. But so many of these patients come to me with nasal obstruction, and we don't dig out that they've got sleep problems until we talk to them. And then, yes, I get the sleep study and I have our sleep medicine guys try them on PAP or, whatever is appropriate. The other thing I will highlight briefly is that we make oral appliances for select patients. So for your milder patients, we use Somnogard. It works very well. I'm happy with it. It's a great tool. There's lots of other things out there, but oral appliances are great for the right patient.
You mentioned patients need to have tried PAP therapy. Is that mostly for patients who are coming to you for like Inspire? Because that's a prerequisite for that? Okay.
Correct.
So if it's a patient that's like, I'm snoring, maybe I have mild or moderate OSA and I can't breathe through my nose, I think I want to do something about my nose. They can come, they don't have to try a PAP.
Absolutely. And we see lots of those. Or the patient who has mild disease who just wants an oral appliance and doesn't want to mess with CPAP. That's easy referral. We do that all the time.
If there is a PAP trial, how long do you want them to have tried it for? What's a good trial? Like, what's a good try?
I'm a little vague about it. And honestly, by the time these patients get to me, they've been on this for years or tried it for way too long. So we'd love to get them sooner. I think they have to try for at least 4 to 6 weeks in general. But then again, if you've got someone with, say, severe claustrophobia or PTSD or whatever, that I'm not going to torture them. Like right now, the indications say they have to try. They don't have to try for a year. They don't have to try every mask on the market. I think that's not good. But I mean, you got to try. And, if it's a mask fit issue, try a different mask. If it's all these sleep hygiene things, try sleep hygiene. All of these things you do have to do. One point of clarification I will make that's interesting, I just learned yesterday. So for Nyxoah, they got their indications listed as one of them is refused CPAP. So you don't actually have to try CPAP for Nyxoah, but you have to refuse it. Now, that's not just I don't want that. Like, it's a pretty strong refuse. But I think that's going to cover these patients, like I said, the claustrophobia, the PTSD, those kind of patients who we're just wasting our time, and just get them treated.
And for our listeners who may not have heard of Nyxoah, can you just briefly explain what Nyxoah is?
Oh, absolutely. So Nyxoah is the company. Genioid is the product. It is newly FDA approved as of 2 weeks ago. So it's a new implant for hypoglossal nerve stimulation. So Inspire has a generator in the chest and a stimulator around the nerve. Nyxoah has a single incision in the midline here, an implant under the tongue here that is touching both hypoglossal nerves, but then there's no generator internally. There's a little stick-on paddle under the chin that wirelessly connects to that. And so the generator is external. You take it off in the morning. A little bit different so far. They're getting very promising results, but it is very early going. And I'm excited to have that as an option for patients soon.
And so getting into the patient visit with you, after you guys, obviously you're taking your history, they're coming in with their nose scores. What about your physical exam? What does that look like?
Right. So there's kind of three main things I think about with a nasal obstruction patient exam-wise. So obviously anterior rhinoscopy, I think every ENT should know how to do that. Everyone gets that. That's pretty easy. The next is nasal endoscopy. So everyone gets a scope. I use a flex scope. I think with the current flexible scopes, you get perfectly great visualization. The only time I use a rigid is if I need to actually be doing something. So diagnostic is all flex. I think it's more comfortable and easy. And then the third thing is a modified caudal maneuver, which hopefully everyone now knows, but I say that and there are a lot of people who don't routinely do this. It is a little bit technique dependent. And the main key, I would say, you're going to occlude the other nostril, and then you're going to prop open the nasal valve area with a Q-tip or a ear curette or something. You want to gently prop it open as opposed to distracting it. So it's tempting to shove the nose open. That's not a reliable test. You want to just kind of support it so that it doesn't collapse as they're breathing, and then do both sides alternately. And I think with the combination of those three things, you're going to figure out what's going on. And what you will tend to see is that about 70 to 80% of people who have nasal obstruction, there's contributions from everything. So there's some septum, there's some turbinate, there's some nasal valve. And more, as we get into this more, we're seeing the septal swell bodies are a much more important structure than we used to think. Again, harkening back to residency, I had heard of the septal swell body. We weren't doing anything about the swell body at the time. We were just oh, there it is. This is really becoming...
It's in my way.
Get that out of my way. But no, it's an incredibly important structure, and treating the swell body, such as with VivAer, is a really great way of helping your nasal obstruction patients. But again, 70 to 80% of people have contributions from everything. Why treat one thing if there's everything?
With your anterior rhinoscopy, do you use a speculum?
Yes.
And what do you see? What does that additional information are you getting from that you're not getting on your nasal endoscopy?
Right. So I think it's the best way to look at the anterior septum. Your scope, you're really only starting after you're about a centimeter or so in. And so you're missing that caudal septum and kind of the head of the inferior turbinate, both of which are important. But to see further back, you got to put a scope in. And one study that I read said that about 20% of people, your decision making was changed by the scope. So that's pretty huge. That's why I scope everyone.
Yeah, 100%. And with the modified caudal, I didn't realize that you needed to occlude the side that you're not distracting. So you need to block that side so that you're kind of isolating airflow through the side that you're going to gently.
And so I just put a finger underneath the nose gently. So I'm not pushing on things. You can see, that's going to affect things. I'm just gently closing it. And again, I'm isolating what I'm testing.
Got it. Okay. And just gently elevating that area of the nasal valve.
Exactly.
And then asking them to breathe. And then it's kind of like a yes or no. Does that feel better? Do you breathe better when we do that? Okay.
And you'll often have to do it 2 or 3 times. The patients, they don't necessarily get what you're asking them. And you're like, no, without. Right. You sound kind of like an ophthalmologist. 1, 2, 1.
Yeah, I was going to say, that's what it reminds you of.
It's okay.
What are you asking me?
And almost, I feel like there's a high percentage of people who will say yes to that question, though, right?
Yes. So nasal valve obstruction is incredibly common. And I think you kind of have to weigh how much of a contributing factor is it here? Is it a minor contribution? Is it a big part? And use that to choose your techniques. For instance, if they've got really, really bad collapse, I think that's someone who's probably better served with traditional surgery, putting in some cartilage graft. But then again, if it's more moderate, I think minimally invasive techniques like VivAer are great. I will say we don't have good comparative data yet. We're working on that. I'm actually taking part in a trial right now that's going to try to address that question of which is the best technique of, is it septoturbs? Is it VivAer? Is it traditional valve repair? That is ongoing research, so we don't have data yet, but I think that's going to be really powerful soon.
Yeah, looking at VivAer versus a functional rhinoplasty done in a traditional way.
Correct, exactly.
Yeah. Are you looking at patients just kind of breathing at rest or sniffing to kind of like see like dynamic collapse outside of the modified caudal?
Absolutely. And I think this is something that also I try to train the primaries to do, is just like ask your patient to breathe through their nose and see what happens. And you will see dynamic collapse. You will see people who are just a very fixed narrowing, all these kind of things you don't need any special equipment for. And so it's an easy thing that is often overlooked.
Do you decongest the nose when you do an exam? Do you do it before and after?
I think before and after is ideal. Oftentimes I'll kind of get in a hurry, so I will give them the spray and then start my exam and then finish my exam once the spray is kind of kicked in. But yes, seeing how much of a decongestant effect there is, I think definitely matters. And I think that hints to how much is turbinate and swell body, because when you decongest, that's what is shrinking, is those two structures.
And a lot of patients will say like, oh, what was that? Can I have some of that? And, I'm breathing so much better now. Like,
yeah.
So that kind of, tips you.
You're like, for 3 days only.
You can't
and
take
actually, that's one of those great questions that I'll ask them after the exam. I'll say is, how are you breathing now versus when you walked in? And if they say, oh my God, this is so much better, I think that's a great patient to be thinking about, again, turbs and swell body.
So potentially just kind of combining those two things, because that's kind of an Aerin decongestant is going to simulate what that would feel like.
Exactly. But again, they may also have some valve. And so, treat what you see. One other interesting thing that the VivAer people have been highlighting that I think is a surprising study for me. So they looked at people who had differing degrees of septal deviation, and they didn't treat the septum. They treated nasal valve with VivAer. And interestingly, patients all got great results no matter how deviated their septum was. So even the people where their septum is so crooked you can't pass a scope, they still got about a 70% improvement in their nose scores, which is wild.
Yeah.
And it kind of makes us all question, like, why have we been focusing on the septum so long? Maybe the septum isn't as important as we thought. And obviously more to come, but I think that that's something that we should really think about is the septum as big a contributor as we were all taught?
And then this study, was it anterior septal deviation? Do they classify like posterior deviation spurs versus like that caudal tip? I mean, I don't know. I think, should I not be thinking about those that differently? I think about them differently though.
I agree with you. I've always thought about caudal septal deviation is different than more posterior deviations and spurs. This study, they graded septal deviation 1, 2, 3, 4 by how much of the nasal cavity was occluded, similar to like a tonsil grading score, which again is not how I have traditionally thought about septal deviations, but it really made me question, made me say, I want to study this more. I want to know more about this. And it also kind of made me think about, this patient we've all seen in residency who's, the old crusty vet who has had a terrible deviated septum his whole life. And you ask him, how's your breathing? He's like, I'm fine. I can't even get a scope through. And he's like, whatever, I'm fine. Maybe there's more to that patient. And I think it is an area for further study.
And how do you think about, I think for patients to have visually collapsing nasal valves, like dynamic collapse when they're breathing, like they have to have the ability to move air through their nose. And so, sometimes you'll see patients where one side will collapse, but they're like,
right.
No, that's my open side. So, and it's like that side's collapsing because air actually moves through that side. And so how do you think about that during your exam, kind of like putting everything together? It's like, okay, well, this patient also has a lot of nasal airway obstruction because of allergies and a deviated septum and big turbinates. But if we only treat that, are we going to then later be like, oh, now the valve's collapsing because there's air moving through?
No, it's an excellent question. And I think where I see that most is like the really bad polyp patient, where they've got polyps spilling out of their nose. They've got no airflow. You have no idea what's going on with their septum or valve because all you see is polyp. And some of these you are going to have to stage, or you'll give them, the round of steroids and antibiotics and everything and bring them back and say, where did this get us and what's going on? But I think some of this, you also kind of get the feel once you've done it enough of like, you see someone where their nose is super narrow and they're allergic and they're full of polyp, and you know that you're going to be treating everything.
How often do you feel that you see patients who have had a history of septoplasty, turbinate reduction, and they still have nasal airway obstruction, and it's, the valve was never addressed? That's
a huge problem. And I see this all the time. Some of that is my bias because people know that I do revision surgery. And so, there's not that many people that do. So I see most of them in the region. But I think it's a big problem. The data is a little conflicting about how common is that, but it's anywhere from 20 to 50% of people who have septo will fail, which is
20 to 50?
20 to 50, which is a really high number. And with the techniques that I use for treating the nose, our failure rate is very, very low. We're on the order of 5-ish% for traditional surgery. That's a big difference. And I think it shows that if you've got obstruction everywhere and you're only treating two of the things that are causing obstruction, you're going to fail because you weren't treating one of the main factors.
Is it because we're not looking for it? We don't know how to examine the valve as well? Why do you think that it's so overlooked?
So I think it's several things. So yes, I think people are not looking for it. And some of it is just training bias of, maybe we were never really trained of how important that is. I think that is changing now. So hopefully the younger generation will be better at that than I was. But I also think a lot of it is the tools you have. And if the only tool you have is septoturbs, then all of a sudden everyone needs septoturbs. Or if you're saying, well, we could also have my colleague do this big operation that I don't know how to do, you're not always going to refer those patients out. You're going to say, oh, let's try a septo and see where it gets us, And so I think things are changing now that we have VivAer, which is an incredibly easy operation technically. Anyone who is an ENT can do it. You can even train your PA or NP to do it. It is incredibly technically easy to do well. And so now in my mind, there is no excuse to not at least think about the valve.
And as somebody who does functional rhinoplasty and treats the valve in a traditional rhinoplasty way, as you think about VivAer, because it is so easy, like was that a hard leap for you to adopt that? Because there's like doing a functional rhinoplasty is a lot more technically challenging than doing this VivAer. Like I feel like when it first came on for me, I was like, there's no way that that's going to be as good. It's too easy.
Yeah.
Like
No, I certainly cognitively I get that. And I am still kind of wrapping my head around that of like, I'll see someone, I'm like, oh man, their nose is a mess. I don't even want to talk to them about VivAer. They just need a big operation. And we're starting to see that VivAer is actually incredibly good for a whole lot of patients, and it will do more than we think. And the other thing is, you know what? If it fails, I can always bring them back and do a big operation. And I've done that a number of times. And I tell people, I was like, look, this may not be enough for you. I would just go for the big thing. And I have been pleasantly surprised a number of times that people are like, no, I'm fine. I don't want anything else. Cool. Love it. And I think that more and more we're seeing that a lot of patients that maybe I was initially skeptical about do great with VivAer.
So do you have hard cutoffs though for who definitely needs an open? Like, is there that type of criteria or something in your practice that you're like, oh, they've had a history of a rhinoplasty. I need to go back and do an open. Like, how do you decide?
I think that's still evolving. And I think my practice is continuing to shift a little bit. So previous rhinoplasty, this is another interesting one of these things. They looked at people who'd had purely cosmetic rhinoplasties. And with older reductive type techniques, kind of the 80s approach to rhinoplasty, up to 50% of them have nasal obstruction as a result of that. Yikes. And so then they treated these patients with VivAer, did not affect the shape of the nose, did not do anything externally, and almost all of them were happy and they responded very, very well. And so that's a great approach for someone who's had surgery. I've also had it with several of my patients who I did a traditional functional operation. They were mostly happy. And they're like, I'm still a bit this, I'm still a bit that, I want that, And instead of taking them back and doing a formal revision, I just gave them some VivAer and they're great. And I love that. Now, I will say, if the cartilage is just thrashed, if there is nothing there to work with, I think traditional surgery is better. And that's the patient who's going to get cadaver rib in my hands. But I've also, again, seen it where, especially patients who are older and sicker or who just don't have any time off from work, those are all people where I'm reaching for VivAer. I just did a case on a lady who's, incredibly sick, home oxygen, even on, high flow oxygen, her sats are in the high 80s all the time. Am I going to put her through a functional rhinoplasty? Absolutely not. But I am going to do VivAer in the clinic on her, and she's going to be happy.
Yeah, and that's good to know too, that it's not like it's burning any bridges. Like if you do VivAer, you're not causing some sort of, scar tissue or problem for having a functional rhinoplasty in the future.
I have not noticed any perceptible difference at all. And I mean, again, I do revision surgeries, so I am used to what it looks like when someone has had previous nasal surgery and how challenging that is. These look like someone who's never been operated.
So back to our patient who's got OSA presenting to you in clinic. You've talked to them. They've got nasal airway obstruction. They've got some degree of OSA. You've done your exam. What happens next as far as further workup and treatment planning?
Right. So I would kind of separate it out in terms of, is this someone who wants better CPAP tolerance, or is this someone who wants to get away from their CPAP? And so, for instance, if they're like, I feel like if my nose is fixed, I could use this, then cool. We'll do whatever we need to do to their nose. We will reassess and they'll be fine. And they can probably get less pressure or a different mask or whatever done. Love it. For the patient who's trying to get away from CPAP, that's when I tend to combine their DICE with whatever I'm going to do to their nose. So do sleep endoscopy DICE at the same time as VivAer in the OR, or sleep endoscopy plus traditional open nasal surgery. I like that approach. I think it gets them feeling better. It gets them on the track of making progress, and it gets us prepared for their implant.
And so if you do decide you have a patient that doesn't want to or can't tolerate it anymore, they've tried it, they did the good try, it's time for the DICE and the VivAer. What's your order? Like, do you go to is the VivAer in the clinic? Is it in the OR at the time of DICE? Right. And do you do DICE first? VivAer, DICE? Like, how do you set it up?
Excellent question. So I do it in the OR, same operation. And so we start with the standard DICE protocol, which is, the propofol of escalating doses every 2 minutes. We stick the scope in, we see how their anatomy looks. And then after I finish that, I say, okay, go ahead. And they either intubate or throw an LMA in, whatever is appropriate for the patient. We do the VivAer and then we wake them up, or do the open nose, if that's what we're doing. And I love that approach. Honestly, about 70 to 80% of the people that I'm doing a DICE on, I'm doing something to their nose. And again, I realize some of that is, my practice, my personal practice as opposed to what's out there in the world. But I think treating the nose should be very common with your DICE.
Yeah. And from a financial standpoint, DICE pays like maybe like $100 or something is like or a little bit more. And so
in general, DICE alone, I am losing money just from an opportunity cost kind of basis. Like I could make more money in clinic. Crazy.
Yeah.
VivAer pays incredibly well. Functional rhinoplasty pays quite well. And so all of a sudden, my DICE, I'm not losing money. I'm at least making a little money.
Yeah. And for the patient too, it's kind of, going to the OR, because I assume it's even though it's a DICE, like it's the same. They're in PO, they go in early, they're in the pre-op. I mean, it's the whole thing, right? And so I think for the patient, it's a little more bang for their buck too, to absolutely have more than just the scope. Yep.
They are making progress, whereas to them, DICE feels like wasting a day, and we're all wasting
for everybody. Yeah, it feels. Do you to that extent, like does scoping patients laying down give you any additional information if they're awake, or they really need to be
not really? They got to be asleep. Really. Now, I will say, even upright awake endoscopy, when I'm evaluating a sleep apnea patient, I just have them take a few breaths all the way in, all the way out. Looking at the palate, you can honestly predict concentric collapse the large majority of the time.
Oh, really?
We've been wrong a couple times, but you can predict it most of the time. And because of that, if someone doesn't need anything for their nose, if they just truly need diced and implant, I am doing that on the same day as much as insurance will let me, which is an increasing percentage of the practice.
Got it. Meaning you would do the dice, and as long as it confirms your suspicion, then you intubate and do the implant.
Exactly.
All together. Yeah. Okay. Interesting.
Going back to the VivAer, so you do the dice, the patient, you do the VivAer to address the nasal valve. How often, is it always, I'm going to go ahead and do the swell bodies and the turbs? Like you can use this, right? The VivAer for the swell bodies and the turbs too. Can you explain that? And what's your threshold? Is it part of like the every time, or how do you decide?
I mean, obviously tailored to anatomy and tailored towards their situation, but the large majority of the time I'm doing all three. And a growing percentage of the time, I'm also pulling out a Ryanair and doing the posterior nasal nerve. And part of that's that I live in Sacramento, where everyone has chronic rhinitis. But it is very, very common that I'm treating everything.
Can you comment a little bit on rhinitis as it relates to OSA?
So less data on that specifically, but again, chronic rhinitis is incredibly common. And I mean, one of my fears when we started talking about Ryanair was that we were going to uncover that everyone needs this operation. I was like, I don't have enough hours in the day for that. But yes, it's incredibly common. And I think that treating it is a good thing. And I think, again, we have less data about that in sleep specifically. It's more about nasal obstruction, but I think it's something that we're probably going to know more about soon.
How often do your rhinitis patients not tolerate CPAP because of purely rhinitis?
Yeah,
is that a common?
I think it's pretty common. And I mean, the chronic rhinitis patients, they're always gloppy and they are always complaining. And I mean, it is a really tough condition. And it's, again, like we talk about tools, like I did not have a tool to treat chronic rhinitis until about 2 years ago. And I spent my whole career going like this and saying, no, go away. I can't help you. And now all of a sudden I can, but we're kind of triaging and seeing like which patient needs us the most. And I think we're still figuring that out.
And as it relates to doing, VivAer with or without turbs and septal swell bodies, can you talk about, is there data that proves that patients are getting better, incrementally better from each one? You know what I mean? Like, is there evidence that if you only treated swell bodies that there would be improvement? Because I think when this kind of first came around, I was like, well, we know turbinate reduction works really well. So are they just breathing better because we're doing the turbinate reduction part, or does this, treating the swell bodies really add that much to it?
So there was a really interesting study a couple years ago called Swell, of course, where all they did was treated the swell body. And those patients did incredibly well. And there's also a great side-by-side CT in that shows, big old swell bodies and then treated and, they're gone.
And that was with VivAer treatment?
That was with VivAer.
Like radio frequency. Okay.
And for that study, they just treated swell bodies, which, again, uncommon that I'm going to be doing that. Most of these patients need everything. And to me, like, I have a wand open. I have all these structures. I'm going to use this tool for everything. I think if that rare patient who just needs their turbs done, I will typically use a shaver just because I don't want to open up a wand for just the turbinates. But again, most of my patients were treating all three things.
And when you're in the OR, do you still do any sort of anesthesia protocol? Is it helpful to inject like you would in the office? So just for comfort afterwards, or because they're asleep, you don't need to? Or
I don't usually. I think giving them a little Afrin is a good thing. And every now and then you'll get a little bit of oozing. And so a little Afrin or a little topical epi is great for that. But no, I don't think they really need it. And honestly, most of the pain is during the procedure as opposed to after. And so most of these patients
so it's a lot faster.
Yeah, it's incredibly fast.
Because the longest, I tell patients, like the longest part of it is going to be getting you comfortable, getting you anesthetized in the office. So yeah, if they're asleep, I assume you can just zip.
Yeah, it's incredibly fast.
So are these booked like 30 minutes?
Yeah.
Like if you have 2 or 3, it's 30 minutes or for an hour? How do you book it?
So I group my dice and VivAer, so it's just a day, kind of like people do a tonsil day. And so I will do 10 cases in a day.
And just because I don't do a lot of swell bodies, but is VivAer our only tool right now to address swell bodies? Or are there other ways people do it?
It's the only one that is specifically labeled for that. You can use the coblator, the little needle coblator wand for the same kind of thing.
Yeah.
I've tried that. I don't like it. I just find it challenging to make sure you're in the right area and that it's not as predictable to me. Also, I like, the idea behind VivAer is that it's temperature controlled radiofrequency. So you're not burning tissue, you are remodeling, stiffening, ablating. And so you get that controlled reduction of the swell without burning everything around it, which you will with other technologies.
Got it. Okay. So as it relates to sleep symptoms and post-op outcomes, talk to us about treating the nose. And, if you're like, let's say specifically treating the nose without doing anything else as it relates to sleep, do we have data that kind of supports improvement in sleep quality or sleep questionnaires or even, AHI?
Yes. So the AHI data is weaker and a lot of it was kind of indirect stuff, but we do have really good Epworth data that shows that your Epworth will drop by about 5 to 6 points with treating the nose with VivAer, which is incredible. And that's actually about the same Epworth decline as with sleep surgery, which is wild. It's not really doing much to the AHI, but it's making you much happier. And then we're also seeing more and more that treating the nose gives you better results with other treatments for sleep apnea. So not just the better CPAP tolerance, but your Inspire patients will do better. They tend to, we talk about the green versus yellow pathway. It is a great way of keeping people in the green pathway by treating their nose.
Can you explain what these pathways are?
Oh, yeah, absolutely. Sorry, I skipped over that part. So when someone has an Inspire implant, we want to know how are they doing with it. And so the green pathway says they have got subjective benefit, they've got their AHI controlled, they are doing well and using the device. And so they have to be at least 6 months from implant for that. But we want to see that, again, they are getting good benefit from the device. And the yellow pathway is the people who are not for whatever reason. Maybe they're not using it very often. Maybe their AHI is still really high. Maybe they're just like, I use it and it doesn't feel like it's doing much. Those are your yellow care pathway. We have some specific things we think about for how do we get people from yellow to green. But more and more, we're learning that treating the nose is an incredibly easy way to do that. Now, like I said, most of my patients, I have treated the nose up front because I recognize that this is, a good way of setting yourself up for success. But I've got a patient right now that I'm working with who, he didn't want anything for his nose. He said, I'm fine. And now he's, not doing so great. We're going to twist his arm and say, look, we need to fix your nose. And I think that I'm confident he will do well.
And is that mostly because just the importance of like being able to breathe through your nose, and that's kind of like, when you're mouth breathing, that affects like the physics and, aerodynamics of how air is moving and how the pharynx collapses. So even if you had an implant, it's like, if you're not addressing that part, you're not going to do well.
All of that is true. And so you want that nice, smooth laminar flow from the nose through the nasopharynx, through the oropharynx, to the larynx. That is the way that air flows the best. And when you have that, it reduces collapsibility of the pharynx. And so then the Inspire implant doesn't have to work as hard to keep the pharynx open.
So have you found that with addressing nasal airway obstruction, the pulmonologist or whoever is managing the settings of the hypoglossal nerve stimulator can turn it down a little bit? They
tend to require lower voltages. They tend to be easier to get to therapeutic settings. They tend to report incredibly good sleep quality. And so you look at kind of the rates of who is green versus yellow. The nationwide data is saying that even 30 to 40% of Inspire patients are in that yellow care pathway. You look at my personal data and it's a lot better. We're maybe 10 to 20%. And I think a lot of that is that we are aggressive about treating the nose. I mean, we'd all love to think that I'm an amazing surgeon. No, it's not that. I know who else is out there and doing these operations. That is not the issue. It is that we are aggressive about treating everything with the airway.
And so the goal is to, if you have this group of patients that are in the yellow pathway, meaning that they've had their Inspire surgery, but they're either not able to use, they have poor compliance, not able to use it, or their AHI hasn't gone down, or symptomatically they're just not sleeping well, and we're trying to move them to green. It sounds like a good percentage of those, I don't know if you know numbers or if you could guess, but if their nose hasn't been treated, that could be the low-hanging fruit to kind of move them from yellow to green.
Absolutely.
And something like VivAer in the office is maybe a tool that could do that.
It's a great tool for that. And again, I don't have a overall data for that. That hasn't been studied separately. I think that's a great idea for a study, is figure that contribution out exactly. But yes, anecdotally, I think that's definitely low-hanging fruit. And of course, you're going to do the other things. You're going to titrate their settings. You're going to talk about sleep hygiene. You're going to make sure that everything else is set up for success. But it's a pretty easy intervention to do that's going to get them feeling better with pretty low cost to them. They are back at work the next day. They are not taking narcotics. They are congested for a week or two. That's not that big a deal. And the complication rate is approaching zero.
As far as complications, what kind of things do you see?
Right. So again, most people are very fine. The biggest risk I tell people is that it may not work as well as you want. And so, sell things right. We are not going to make you perfect nasal breathing. We're going to improve your nasal breathing. When we look at the nose scores, we're shooting for about a 70% reduction in their nose score. So they are still going to have some symptoms. Well, it's with Ryanair more than VivAer, but we have to talk about severe epistaxis because one of the studies had a significant rate of that. I think that was technique based, that they weren't spacing their lesions. So you want to kind of checkerboard things. So there's normal tissue in between and you don't treat one area more than once. When that study was done, we didn't realize how important that was. And so as a result, they were getting a lot of energy in one spot, and that was leading to nosebleeds. Again, I have not seen that complication, but it's in the literature. We also talk about, nasal dryness, as with any kind of thing. They talk about empty nose, although to my knowledge, I don't know of any actual cases of it with VivAer, which is a nice thing. I think we've all seen people who've had a aggressive turbinectomy and are really miserable. I don't want to cause that ever. And VivAer, as far as I know, I have not seen any empty nose.
When do you repeat the nose survey or the questionnaire to determine if we've gotten that 70% improvement?
At least 6 to 8 weeks, and probably even a little bit longer. We're all tempted to get it like at that first post-op visit because it's right in front of you. It is not reliable at that point, and it does take at least a few weeks before they will feel better, and they don't hit steady state until 2 to 3 months. And so, I tell people it's the roller coaster of instantly in the office right after I finish, they will feel better. Some of that's just the decongestion. Some of that is the treatment effect. And then they build up swelling for 2 or 3 days, and then they get better slowly. By the time they see us for the 1 to 2 week post-op visit, they may be kind of right where they started. They may be a little better, but they're not all the way where they're going to end up. And so we got to be patient, and you got to wait on that nose score until they are healed.
Got it. And you have them do like some nasal saline sprays or something afterwards. Do you like spray, mist, like actual irrigation?
So I like anything you can convince them to do. But I think I like the actual squirt bottle and really flush it out and irrigate, get all the crustiness, get all the boogers, get everything cleaned out. I like them doing that at least 3 or 4 times a day for the first couple days, and then they can taper based on how they're doing. The other thing that's really important for the crusting is lots of Bactroban. And so I know we're used to prescribing it to maybe 3 times a day. Anytime they're thinking about it, get some Bactroban in there 4, 5, 6 times a day. Keep some Bactroban with you. That will definitely cut down on the crusting and make them happier sooner.
Got it. That crusting that kind of develops just inside the...
Exactly. Kind of right on that area that you treated, it gets crusty. Yeah. And I tell them, go to the depth of the cotton part of a Q-tip. I think a lot of these people they're going way, or if they want to go way too deep, you don't need to do that. Please don't go for brain. But about a centimeter in and just kind of all the way around.
Cool. And for patients who you've treated their nose and now let's say they have an Inspire implant and they're still in that yellow pathway, what other things are you addressing? Is it a weight loss thing? Are you prescribing Mounjaro or anything?
Right. So I don't prescribe any of the GLP drugs. So the GLP drugs are great. And there is now for Zepbound or tirzepatide, there is a specific FDA indication for OSA. That study showed that they got about a 60% reduction in AHI with weight loss, which is great. But then again, that's not everything. And, you take a patient who comes in with an AHI of 60, now you've got their AHI down to 25, they've still got a problem. But yes, weight loss can be incredibly helpful. And I think checking your settings on the device and working with either, we have an NP in my practice who is one of the few people who's signed off on the whole care pathway. So he can manage yellow care patients without involving us. That's awesome. I love it. Makes my life incredibly easy. But having someone like that or an experienced Inspire rep so that they can really titrate the settings and get the right configuration for your patient, that can get a lot of these people from yellow to green. Weight loss when possible, that's great. GLP-1 agents are great for that. I don't prescribe them. I have our endocrinologists or our primaries will do that, but they're a great resource for the right patient. Also, one other point about weight loss, treating sleep apnea makes it easier for patients to lose weight. So we talk about, you should lose weight in your sleep.
I thought it was the other way around. It's
a little cycle.
Like our outcome. Yeah.
And
okay. Tell me about it. Yeah.
If you have a patient who comes to you and they're obese and they have sleep apnea and you can get them to lose weight, like I said, you can get their AHI down maybe 60-ish% with GLP-1 drugs. That's great. But say I've got a patient who's kind of heavy. They're still in the Inspire range. We implant them. They will often lose weight. And it's because when we have sleep apnea, we're in this constant stress state. Our body is holding on to the weight. Our sleep is interrupted, so we're not getting those normal kind of refreshing sleep things that help people to lose weight. And then you treat them and you get them better. And all of a sudden they're like, yeah, I have energy. I go to the gym. I feel great. Pounds are dropping. That's awesome. I love it. And so actually one of my first Inspire patients, back when I was starting, she's been struggling with weight forever. She lost 50 pounds after her implant. And she was kind of right at the top of our BMI range for Inspire. And now she's feeling great. She still needs the Inspire, but we've got her on pretty minimal settings and she's overall a whole lot happier. And that's what we want. That's why we do this.
Yeah, and that makes sense. I think that with everything that's come out about the importance of sleep and what happens during sleep, and I think that if you're getting crappy sleep every night, it makes sense that would affect, your overall health. And so that's great. As we round things out, Scott, what else do we need to touch on? Anything else to leave our listeners with as it relates to nasal airway obstruction and OSA, nasal valve collapse?
Again, I think one of the big topics with the valve, again, we now have a tool that anyone can use. We didn't before. I think we will know more soon about what tool is right for what patient. We're working on that. But in the meantime, let's use the tools we've got. Let's use our clinical judgment. Let's take care of patients. And let's not forget about the nose. And I think that this is something that is changing the sleep world and changing it for the better, that we can get better outcomes when we think about the nose.
Thank you, Scott. Learned a ton.
Awesome.
Thank you. If any of our listeners want to reach out to you, or if they have any questions, are you on any social media, or they can always reach out to us and we can always connect them with you.
I'm happy to field any questions for people. I'm on LinkedIn with my name. If they go to the Dignity Find a Doctor page, or if they have patients they want to refer, I'm happy to see people. Busy, but always happy to take care of patients. I know we're all busy. There's not enough ENTs in this world. But LinkedIn's probably the easiest place to find me. Or again, for things that you guys get directly, I'm happy to answer questions. I want to be there and be a resource for people. And like I said, I think we can all do a better job of optimizing how we treat the nose.
Awesome. Thank you.
Thank you.
Right, thank you so much.
Thank you so much for listening. If you haven't already, make sure to subscribe, rate the podcast 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ENT on Instagram, LinkedIn, or Twitter. BackTable ENT is hosted by Gopi Shah
and Ashley Agan.
Our audio team is led by Kieran Gannon, with support from
Aaron Bowles,
Gabe Legrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess.
Social media and PR by Chi Ding.
Administrative support provided by Judy Dela Cruz. Thanks again for listening, and see you next week.